thanks for joining the DFMPC and CHSC Professional Learning Series. And today we've got Mati van Niekerk and Nabila Sujay speaking about disrupting the culture of feedback in health science education, creating a culture of patient participation and student evaluation and feedback. And I think this is going to be a very interesting talk. Thank you, Mati and Nabila, for hosting this, and please go ahead.
Thank you, Johannes, and hello, everybody, and welcome again. My name is Mati van Niekerk. I am an occupational therapist and an occupational therapy lecturer. I am going to take us through this thing, if I can get my slideshow to run from the beginning. Right. So I want to acknowledge Johannes for some of the legwork that he's done to help us, and the additional readings in this presentation actually comes from Johannes. So thank you, Johannes, for that. We've been speaking about deep and meaningful learning over the past, I'm very sure, 2 years going on that I've been attending the professional learning series and some of the other events that have happened in the university around, well, at that stage, the emergency or moving to the online platform. But we do know that for students to develop deep and meaningful learning, one of the things that they need is constructive feedback. There's been a lot of research actually on feedback. And so perhaps we just need to stop and stand next to some of the research and some of the literature around feedback so that we can understand what it is that we need to do to get patients to also provide meaningful feedback. So the literature says that feedback has to be quite specific in order to be useful. Feedback needs to be frequent and in small chunks of the curriculum to allow students to measure their progress. So if they get a big bunch of feedback on a large proportion of the curriculum at once, it's very difficult for them to digest it. So it's like eating an elephant in small bites. Feedback must tell students exactly where they've gone wrong and how they can fix it. It's not just about telling students what they did wrong. We have to also help them to fix it. A focus of critical feedback on personal characteristics of a student can really be negative and demotivating and negatively affect students' self-efficacy or their sense of competency. And self-efficacy is strongly related to effort and persistence with tasks. If you have read up on Bandura's theory of social cognitive learning, you will know this. And I just want to say that a disclaimer is that I absolutely love Bandura's theory for a couple of reasons, the most important of which because it links so very closely to my profession, where self-efficacy amongst people with disabilities to start their lives or to re-enter into activities that were important to them previously is so important. So self-efficacy relates to effort and persistence with tasks. So if things are difficult, do they stick to it? It predicts academic achievement and is associated with adopting a deep approach to learning. So if we give feedback that helps a student to develop self-efficacy, it facilitates deep learning. Feedback about content provides the students with options for action and is less closely associated with their ego. So if you give them personal feedback, their egos get in the way. But if we give them feedback about content, it gives them options for action, and it's about their action rather than about themselves. It is very, very important that feedback happens fast enough, because if students have moved on to new content, the feedback is irrelevant, and it's extremely unlikely for them to have deep learning that is related to the feedback. Imperfect feedback from a fellow student that's provided almost immediately may have more impact than more perfect feedback that happens later by a tutor or a supervisor or a clinician or a lecturer. For large classes, they found that if you do remedial tutorials directly after a test, even though it's not individualized, students are able to learn what it is that they did wrong and how to fix it because it happens quickly. after the test. Feedback must be appropriate to the purpose of the assignment and to its criteria for success. Therefore, students have to understand what the criteria of the learning activity or the assessment task is so that they can orientate themselves properly to that activity. And they need encouragement in addition to only correcting their errors. And that also comes back to a sense of self-efficacy, vicarious learning, and the other notions from Bandura, social cognitive learning. Feedback must help students to understand the standard to which they must aspire. Norcini and Birch said that there are some specific conditions that we need to put in place to make feedback more conducive to learning. So we need to set an appropriate time and place for feedback. It shouldn't happen on the fly or in a rush. Everybody needs to be properly prepared for this, bearing in mind that it still needs to happen very soon or as soon as possible after the learning event. Provide feedback regarding specific behaviors and not general performance. Give feedback on decisions and actions and not one's interpretation of the trainee's motives or intentions. And we see that often in the clinical space that we assume what a student's intention was rather than giving them direct feedback on decisions and their actions. Again, feedback needs to happen in small digestible quantities and use language that is non-evaluative and non-judgmental. There's no point in being ugly, and there's no point in being cruel. And we know that from reviewers who review our written work when we submit articles for peer review. And if you do training on being a peer reviewer, that's one of the first things that they tell you is to be kind and not to be cruel, not evaluative and not judgmental. It's important to create a respectful, open-minded, non-threatening climate. Elicit thoughts and feelings before giving feedback. So how do you feel about this? What do you think? How do you think you performed? Rather than jumping in and just digesting and dissecting and judging. Focusing on behaviors, being non-judgmental, basing feedback on observed facts. When I saw you do X, this is what this is the chain of events that I saw happening, rather than I think you felt or you intended or whatever. Basing feedback on specifics, and again, not being vague, not being general. Giving the right amount of feedback. This is so hard to get right because we want to jam pack everything into a session. And I experience this myself when I give feedback to our final year students after a treatment demonstration and a case presentation. There's so much that we could tell them, but we need to actually temper it. And you can see in a student's eyes when they start feeling flooded and they start feeling as if they're drowning in all of the feedback that we're giving to them. Suggest ideas for improvement. So it's not only good enough to say what they did wrong and to make them think about how they can fix it. Help them to fix it. Give them ideas of what they can do differently. Basing feedback on well-defined and negotiated goals. So what are the goals that the student is setting for themselves from a learning activity or from an assessment activity? And I often do that with my fourth years when when we start a block to say, what is it that you want to learn from this entire 7-week experience? And trying to then link the feedback that I give them after a treatment demonstration or after a case presentation to those goals that they've set for themselves. And we negotiate those. It's not a question of them just giving me a list of things. We unpack that to make sure that the goals are well defined and not vague in of itself. So that then brings us to patients and their place in the clinical curriculum. Now, we know that health professions education is different from other kinds of education, or it's postulated that it's different because we stand in a triangular relationship that few other educational situations have, because we have a teacher, a student, and a patient involved in the learning setting. And there's a long-standing history, and I'm not going to unpack the history of using patients in clinical teaching. There is an increasing movement towards using standardized patients in clinical assessments, especially in determining students' readiness to enter workplace-based settings. And this you would have seen from the occupational therapy paper that we circulated prior to the to this afternoon session. A learning activity with standardized patients provides an authentic, purposeful experience, encouraging deeper thought and self-confidence for the students because it gives them a practice round of what it is like to be handling a patient with a specific kind of condition or from a specific kind of background without the threat of the real clinical environment and the fear that I might drop the patient or I might hurt the patient or something might go wrong. An SB or standardized patient can be an actor or a real patient with a condition or a disability who are trained to present in a way to challenge a student in their learning process. Using standardized patients in education can add the potential for facilitating and assessing non-procedural skills, including integrating their knowledge. So assessment is an important part of learning, and assessment has an administrative component to it and a learning component. And Johannes and I were just chatting quickly prior to the session starting about quality assurance in our assessment, and the administrative part of it is so important. How we plan for an assessment, how we present an assessment. So how do we do an assessment, and what's all of the things that are involved in that entire process to ensure the quality of our assessments. And I think that we sometimes are quite pressured because of student volumes, because of the balance between undergrad and postgrad students, that we sometimes neglect the administrative component of our assessments, and even in the clinical context. And sometimes we might not even think of it. So there is a misconception that the clinician or the academic should be the only source of feedback for student growth. But there is a growing body of literature that shows that ideal assessments should include feedback from multiple views and stakeholders. So if your student is not a nursing student, what feedback can the nurses give you about your students' performance and about their engagement in the multidisciplinary team? So who should be providing feedback? There's lots of papers that say that there should be 360-degree feedback, which includes peers, so in other words, fellow students, clinicians, and academics. But then why not include patients also? A study by Bjorklund and al. Found that patients' feedback facilitated a reflective, self-directed learning process with the identification of learning needs and increased awareness of the patient as a collaborative partner during the encounter. Now, patients being collaborative partners is actually rather important because we often see that students view patients as a commodity, and it comes from their attitude of having a right to access patients. We had a big issue in 2020 with the hard lockdown with one of our year groups that felt very hard done by not being able to access the clinical training platform, and us reserving the clinical training platform for our final year students. And their attitude about them being denied a right, and they have a right to access patients, actually translated into their behavior in our use of a simulated situation, with them refusing to learn from that situation. And it was actually fascinating to see how their attitude affected their learning. And therefore, if they actually saw that simulated patient and the simulated situation as an opportunity for collaboration and for learning in a different way, they would have actually been in a better position. We also sometimes see students treating patients as if they are an obstacle to their marks. We do see that from time to time in the OT setup, where students view some of their patients as difficult. In that they are obstructive. They think that the patient is being purposefully difficult. The patient is being purposefully secretive. The patient lies on purpose to them because they simply just don't get down to seeing patients as a human being and as a collaborative partner in the encounter. And they don't see what it is that they can learn from the situation as well as the person. Importantly, faculty needs training. And faculty, in my view, includes everybody. So it's the academics, the clinicians, the patients, or the standardized patients, but also students. People need to learn how to assess or how to score performance so that they can provide feedback to a trainee that is useful. The interesting thing for me in the Norcini and Birch paper, when I first read about stringency, I thought that it's because people are too strict. And in fact, Norcini and Birch are lamenting the fact that people are not stringent enough. We often speak about the hawks and the doves in our OSPE situation, where some markers are very strict and other markers are very lenient. So how do we set an adequate bar for stringency and also make people comfortable with providing feedback? And for me, it comes back to the question of what are the standards and what are the objectives of the learning activity, and how do we measure those in an assessment task or in a learning activity. And of course, the quality of feedback is important and whether the feedback is actually useful. And it's not useful if it's not specific and not timely and so on. So the question that we are posing to everybody today is how do we make it work? Should students leave an encounter with a patient without hearing from the patient about their experience of the student as a healthcare practitioner? And what format should be used for patient feedback to a student? In the Bjorklund paper that we circulated, they've used a standardized form, and there's a very interesting article that shows how they actually developed that form or checklist, which, as an aside, provides a nice flow diagram for people to develop checklists. But is that the only way? Is it the best way? And how do we then structure those forms or checklists so that students can actually learn from it and that it isn't personal? If we are going to use standardized patients and then use standardized patients to have them give feedback to students, how do we select standardized patients? And what training do they require? I think that the OT paper alludes to that to some extent. And can we have multi-purpose standardized patients across disciplines so that we have a pool of standardized patients that we can use to provide feedback to or that we can use in assessments of multiple disciplines and not OT specific or physio specific or BCMP specific? How do we get, for want of a better word, multi-purpose standardized patients? And also, if we all run to the WITS drama department, we're going to run out of students to use for standardized patients. So how do we make this work from a practical perspective also? And then how do we structure feedback and incorporate the feedback into the students' marking, whether it is from a formative perspective or from a summative perspective? Individual or collated into a tutorial? Do we give direct feedback and indirect feedback, or is it only formative, or do we give summative feedback from patients also? And how do we weight a patient's feedback in a summative assessment if we are going to include it in a summative assessment? So if we have enough people to participate, Just want to get back to Teams so that I can stop sharing. I don't know. I usually, when I am in one of these workshops, I have to admit that some days I do run away when the group discussion thing starts happening. So Jonas, what do you think? Do we break? Do we have enough people to break into chat rooms, into work groups, or do we just have a general discussion? I did prepare a thing, a Jamboard, in case anybody wants.
So I see there's about 17 people. So I think there is enough to break into like 3 or 4 groups.
Okay, there's the link to the Jamboard. It has all of the discussions. So, Jonas, if you want to do the honors.
Okay, great. I'll do so now, and I'll also copy the link to all the groups once you break away.
Okay,
Yes, Nabila.
Nabila's hand is up.
Hi, Anas. Good afternoon, everyone. So I just wanted to give a little bit of maybe a background to get people's minds thinking, if that's okay.
Sure.
Okay, so good afternoon, everyone. So for those of you who don't already know me, I'm Nabila. I run the simulation lab on the 4th floor. So if you're not sure where that is, that's your hint to like come to the 4th floor and see the cool stuff we do there. So for all intents and purposes, this is the part of the session where people hate and where we get you to talk. So whereas you went home and took off your shoes and got very comfortable, we're going to get you to talk a bit and just to jog your thinking before the breakout rooms happen. The idea behind the discussion is sort of threefold, well, fourfold. The one would be think about, how we use SPs in our assessment. And if we're giving feedback, how valuable is that? And should we even think about it? And the literature says things, and we'll post some additional articles in the chat, but that's sort of the one big question. What's the value add of SPs giving feedback? And that's the big picture question. And then the other 3 questions that sort of come up is, okay, so if we decide it is valuable, and that's the discussion we'll facilitate, then how do we select these SPs? Because if these SPs are going to give feedback, do we have to be selective, or can we train people? And when we train people, what does that training look like? Yes, and then you're going to talk about limits and challenges and opportunities for collaboration. And that's the kind of wheels we sort of are wanting to be turning in your minds. So the first would be value add. The second would be how do we select these SPs? The third would be think about the training needed and the resources needed to do this. And then the last question to think about once you break up would be, now that we want to do this, do we do it in formative or summative assessment? And if we include SP feedback, should it be direct or indirect? Does it have to be directly to students in the room or in the OSCE setting or the observed consultation setting, however it is? Or is it indirect? Do we get the SP to give feedback to the examiner? And should the examiner include that in the rubric, in the weighting? And what would be some thoughts around that? So the hope is that, you got about 10 minutes to sort of discuss these 4 very big picture things that can go on for forever. And then you kind of come back and we look at the thoughts that came up. So I hope that sort of makes sense.
Thanks. Yeah, it does. Okay, so I'm going to break you up into, so how many groups should I do, Nabila? 4?
I think that's fine. And if you could try and make sure that maybe each of us is separate, so Matty and I don't go into the same group.
Okay, cool. I'll see if I can mix you around. I just need to see if I can. Sorry, I quickly need to. Okay, so automatically assign. We want full groups. Create rooms. Okay, we're almost there. It wasn't. I'm sorry,
Yeah,
I pulled everyone back because Anastasia's room wasn't working. Shira's, there were people like in Shira's room also that couldn't access it and stuff. So I think there's a glitch in the system. So I think we should just have a general conversation that everyone can join.
okay. Well, we were
Okay.
getting very involved there.
Sorry.
As were we.
Sorry, Matti. I guess you didn't hear the part. So there were two rooms not working where
Yeah,
people
no, I heard that.
couldn't
Thank you.
join or not. So I just thought maybe let's just do it in one room discussion.
Okay, so shall I just start with some feedback? We were just getting into a nice nitty-gritty of a discussion in our room on our Jamboard, and people thought that it's a great idea to include patient feedback in an assessment, because students need to understand what the treatment is, and what makes a patient uncomfortable, which things do patients accept, and then also the notion that patients in the public health sector don't necessarily always speak out when they're not happy. So if we include their feedback, then we're actually giving some level of agency to the patients. When using standardized patients, so there's some people in our group who had some experience with that, how they prepare the patients for knowing what is the right thing to do is that the clinicians actually do the procedures in an OSCE first, to show the patients what it will feel like if an experienced or if a procedure is done correctly, and they also, the patients, standardized patients, have access to the OSCE rubrics or OSCE sheets, so that they have an idea of what's expected and what's the point. But then the question that was raised was about whether it's the feedback should be freely given or whether it's structured. And some people don't have trained SPs. We just use whomever we find in the ward, and that happens to many people. So that was just a little bit of the discussion from our group.
Yanis, I'm not sure if you are leading this side or can I jump in?
No, you can jump in, Nabila.
Thank you. Anastasia, I see your hand. Maybe before I just jump in. Can't hear you though. Anastasia, I'm not sure if it's network, but I can't particularly hear you. I'm not sure if it's me.
Can you hear me now?
Yes, we can.
Okay. I said Mervin's hand was up before mine. I don't know if he wants to speak or he's good. Mervin, can
Thanks,
I go ahead?
Anastasia.
Yeah.
We had just started speaking not only about academic feedback, which is obviously critical. I mentioned that in many instances, these students are academically competent and they're able to chuck out the information that is required. But I think feedback in terms of how they behave professionally, how they express themselves verbally, how both in tone and in choice of language, and how they use their body language in terms of communicating with a simulated patient or even with a real patient, and how they communicate that information, A, to the patient, and B, with the examiner. And I think we have to encourage them to develop a very professional attitude in terms of the way they talk to people and to colleagues. So that was the beginning of our discussion. Thank you.
Thanks, Mervin. I think that's so important. And I mean, just coming back to that interpersonal thing, I think as examiners, it's so easy for us to give feedback on what we perceive the students to do. But there is that notion of communicating with a student and then feeling or reacting to how the student reacts towards you and just their basic attitude. Anastasia?
Thank you so much, Nabila. I'm really enjoying the session. So as Matty was sharing, or as you started posing the questions, I remember the very first time I tried SP feedback. There was no prior training. It was literally more or less like Mervyn said. I'd wanted for the students to also get not just, it was a FOSCI, so it was an OSCE session with feedback. And it was the students' first time of doing an OSCE, and we had wanted the SPs to also evaluate them. So, you know, your question 4 about directly or indirectly, within a setting where there isn't training for the evaluator in terms of giving a rubric for the SPs to give their feedback, you know, where you just throw out, how did you feel about this session directly with the students there? It can really go north if it's not a controlled feedback session with the SP understanding the essence of giving feedback and the manner in which to give feedback. So the experience I had, we had a very loud SP, and she just went, "You guys were horrible, very terrible." You know, it was very, so the students left. So the point I'm trying to make is that if an SP, the same way we would train them to be standardized patients, I think before we involve SPs to give direct feedback to students, it would be necessary to train them. First, give them a background. And I'm sure there must be a rubric, and help them understand that this is a controlled environment. And within 6 minutes, I don't know. I think there should be a lot of training that happens for that. Conversely, I've also had experiences where I'd relied more on indirect feedback. So the student steps away from the exam, and then I'll say to the SP, "Tell me how you felt if this was your doctor in a real life encounter. How did you feel about this doctor?" And some of the feedback that Mervyn has already said will come through. They will speak about the doctor's attitude. They will speak about being engaged with as people, not just as a case or as an exam. They will speak to and even if it always would give a global, you know, with the global score that we would employ in an OSCE, I always would somehow just incorporate that. Because when an SP says to you, "I know it was an exam, but I like the confidence with which with which the students approached me. I like the way they spoke to me," or vice versa. It helps. Thank you.
Thanks, Anastasia. I think you actually captured almost every point I had for this discussion really nicely. And I think all of us almost do that, because I know in all of our OSCE rubrics, we have this thing at the bottom that speaks to communication and how the student made the patient feel. And I do that as well. After the OSCE, I ask the patient, like, "Didn't you feel a bit interrogated in that thing?" Just to know that it wasn't just me feeling it. But I suppose there is the other aspect where the SP might feel a little bit sorry for the student and want to default to being a little bit more lenient. So maybe that's also something to think about. Aviwe, I see your hand.
Thank you. I jotted down a few points, and I was just thinking about the power dynamics, you know, in that moment of giving feedback, that typically, you know, the lecturer has all the power and the students are sometimes intimidated. So if you were to use patients and simulated patients, then that power dynamics is also, it's changed, it's challenged. And I think there may be benefit there where the student is able to be maybe open to receiving feedback from the patient themselves, and there's power in the actual patient also just giving input about their lived experience to the student to say, you know what you did, it made me feel this way, or your performance was not so great because I would feel in a certain manner. So they're telling them, they're giving them that first-hand type of response. And I see it to be quite powerful because that's the person that the student is going to be accountable to at the end of the day. So they're having that first-hand type of information. Then for the SPs, you know, SPs watch us teaching skills like all the time. So through repetition, they're also picking up what needs to be done. And I've often had SPs whisper in my ear to be like, but did the student do it right? And I'm like, you can tell them, you know, if you see something. But I agree with Anastasia to say there needs to be that training of the SP as well in terms of how then should they intervene, how then should they show the student what to do correctly. So I love both ideas, the patient giving the feedback and also the SP giving the feedback.
Definitely. And I think it comes back to what you were saying, the power dynamics. And there might be this hidden thing of now the SP actually feeling empowered and having a stake or a role in patient assessment. And there are a few universities abroad that have actually developed this. I think there's one in Sweden, if I'm not mistaken. I think there's an article that's in there that has what they call a simulated patient program, where they actually do training and have defined criteria. So maybe here's a question to throw out to everyone. What would you want in that criteria when we are doing a training program? What should we be training? What kind of themes do we want to look at when we're training these SPs? Anastasia, please feel free.
Thanks, Nabila, and I hope I'm not being too vocal, but this is quite interesting. So just leveraging on what Aviwe said, I think the power dynamics can also flip either way. You know, sometimes you have students who are confident on a giga level, and then you have SPs who are, you know, quiet, and when they start giving their feedback, I've seen that happen. And then the student says, but no, I was meant to, and then they, you know, they kick in with their medicalese, and then the SP just feels, oh, maybe I wasn't the right person to say that. So, which is why training is important. And I think it's training 360 degrees. So training for the students or whoever the learner is, to say you are going to be exposed to a view from the patient in terms of how your engagement with them made you feel. You need to not become combative or I don't know how to, well, I guess those are factors we need to put in, that the student doesn't navigate or gravitate to either sides of the pole in terms of receiving feedback from a patient because they feel, now this is medical training. What does this patient know about this? That's one. Then two, the other part of this is training for the evaluators in terms of positioning the whole engagement in a way that there is a nice spread of power, like Abiwe mentioned, where the evaluator doesn't become the know-it-all and be-it-all, that the SP or the patient knows that their feedback counts, and they've been trained on particular categories or rubrics or areas in which they're meant to give feedback and areas in which they're not meant to give feedback. So almost like giving a proviso to say to the student or to the patient, we're not asking you to evaluate the skills or the hard skills in terms of, did he do an abdominal examination according to the sequence, but we're asking you to evaluate the attitude and the environment and your perception of his of the learner's patient-centeredness. So I think there's a lot to speak to whoever is giving feedback, what their boundaries are. But thank you. Interesting conversation.
Thanks, Anastasia. I think 100%. And for me, I'm picturing a situation where the buy-in for the SP to give constructive feedback would be to tell them that, I mean, this is someone who's going to treat, the community once they're out there. So however you felt in their interpersonal relationships is the feedback they're going to take and remember. And one of the articles actually has student reflections. And it says that the student now feels a lot more self-aware of their demeanor, of their attitude, of their patient relationship skills, and just their development of rapport. And I think that feedback is so important. Lizelle's also putting in the chat that, some of the criteria we can speak to is how the student made them feel. So we're looking at communication. And I mean, that can be a really nice rubric for that. I'm not sure there's any other thoughts if we've, rattled your minds enough. Any other burning thoughts about just sort of what we include, what we'd ask the SP to give feedback on? So maybe I throw another spanner in it. In that I think one of the last things Anastasia was saying was we telling the SP that this is not, you're not going to be evaluating the student. But now I sort of throw it to you to say, what if the SP does have a stake in evaluating the student? And what if we include a component in the rubric to say, this is the mark the SP gives? And of course, with good training. What are people's thoughts around that? I'd be shocked.
Nabila, do you mind just asking that question again?
Sure. So if we say that the SP does have a stake in evaluating the student, so let's say, practical example, we're sitting in a practical examination, be it in any discipline, and the patient is, well, the SP is there, the student is there, the examiner is there. We've got the rubric, and the last portion of the rubric is for the SP to give the student a mark. And should we include that in terms of the interpersonal relationships? Because the examiner does it. The examiner assesses the communication and the interpersonal relationship. But my question to everyone is, should we get the SP to actually be giving that mark? And Lizelle actually has put it quite nicely. Does the student instill a confidence in you that they are safe, that they are a safe practitioner, that you feel comfortable with them? Yandisa, I hope I've made it clearer.
You have. So I'm just wondering, could it then not be something that is that section, half of it comes from the patient and the other half comes from the examiner? Because I think there is a perspective that a patient might not necessarily have. And again, I've only practiced in the public health sector, but patients' expectations sometimes are very low. Let's be fair. Where patients feel like I'll give an example, when you ask them what option they would like to choose, well, you give them options for management or management options. And when you ask them to choose, they say, whatever you think is best, doctor. So I feel like there might be, but then again, if you train the patient, I guess you could, but I still think you need both the examiner as well needs to also contribute to that assessment.
I do agree, and I think with good training we can get our SPs to give really nice feedback. I'm going to take, I think it was Anastasia and then Mervyn, and then Matty. I was actually going to throw this one back at you but you put it in the chat because I was going to ask it. Have we thought about patients with disabilities and patients with profound disabilities, and how do they give feedback? And I'm going to leave that thought with everyone for now. And then just, I think Anastasia might have wanted to respond.
Thanks, Nabila. So two things. First off, and I do agree to having a section in the rubric that speaks to the SP or the patient's evaluation of their engagement with the learner or the examinee or assessee, if there's anything like that. The only challenge I have with that is when we say, for instance, in an OSCE, an objectively structured clinical examination, is the SP or patient's evaluation objective or is it subjective? And I'll tell you why. So you can go into a doctor who makes you feel good, makes you, like Yandisa said, says the things you think you need to hear, but is not going according to guidelines. Is literally doing everything wrong, but doing it in a very nice way. And so the patient leaves with this, oh my God, I love that doctor. He was so kind, but he was kindly killing you. So will that be an objective assessment in that sense? Or will we have to look then at the weighting? So if, for instance, in the very first part of the rubric, this patient is globally poor from the practitioner evaluation. I mean, he's done everything wrong. He's literally, for a patient with, for instance, with trauma, instead of immobilizing C-spine, has gone shaking the head or doing something funny, or but has done it in a very nice way. And then the patient feels, the SP feels, yeah, he's done the right things, but he's actually been very unsafe. So will we then look at either renaming an evaluation that incorporates objectively an SP or a patient's scores and possibly call it something else? Or will we then weight the SP's feedback and look at it holistically in terms of if this was a globally borderline or good student, then the SP's weighting will count. But if this student is borderline poor or is like an outright fail, then the SP's evaluation would only have a limited affectation on the marks. I don't know if I'm making sense. Then with the second one, I really love the concept of how will the patient who has a disability assess? And I'm already thinking, do we have a color? So if we're not wanting to, because I can tell you for sure that, like Yandisa said, if you say, except it's a very well-trained SP who is confident about being an evaluator over and above being an SP, if you said to them, your evaluation is going to be a part of what makes or mars the students' marks, some of them could become very subjective. But if we give them a color chart or like, the pain chart, that like a grading 1 to 10, what would you give this student? 1 being this, or yellow to red. My thoughts. Thank you. Just thoughts. Thank you.
Thanks, Anastasia. I like that. I think the sort of chart. I think I'm going to let Matty come in on the patients with disabilities, because I know in occupational therapy they use those patients. They treat those patients quite a lot in the spaces and in the hospitals especially. But I think to your first point in terms of if the student is unsafe, and the SP felt very kindly treated by that patient, it comes back to a viewer's point in the chat around training. And I think that's our biggest thing, determining the leniency versus not. Should we include it as a weighting in assessment? Is that in all, and I mean, this is for general evaluators in all our assessments either way, we have to train our evaluators to live up to or to assess according to the standard we hold the profession to, and we hold the core competencies that we want students to graduate. And unless the SP understands that, then of course the leniency comes in. But I'm going to just hand over to Matty.
Yeah, I think that is a very interesting question, and I think the notion of safety is an important one, because any patient can tell you whether the student had made them feel safe. You can use different kinds of words. It does require some skill on the part of the clinician or the examiner or the academic to incorporate the feedback from that patient. But we also need to then make sure that the patient is actually safe when they give the feedback. So it's not just about safety when the student is handling them, but it's also about safety when they are giving feedback. And we'd have to think a bit about whether we do it, whether it's direct feedback or indirect feedback. And there might be different nuances to that potentially. I do think it's time for us to wrap up. It's 16:58. So just from a conclusion perspective, I think that the discussion, if we wrap it up, it's important for students to actually see that patients are not just a commodity, that they're a collaborator. It's important for patient empowerment. That came out quite nicely. It's important for student learning on the part of the academic, because there's things that we can learn also from the standardized patients. Training is crucial on multiple levels. Faculty training, standardized patients training, but also someone mentioned the fact that it's important for students to be taught how to receive feedback and how to respond in the situation to feedback. Do you think, though, that one thing that we didn't say, but perhaps needs to be vocalized, is that we need to start collaborating more? Interdisciplinary collaboration, because we do, many of us do the same thing in silos, when there's lots of opportunities for us to actually to collaborate. And I do think something that I'm very concerned about is CTG funding, and that's standardized patients and collaborative OSCE exams, because OSCEs can be, and OSPEs can be expensive. If we collaborate a bit more around those things, we can actually be a bit more cost effective and efficient. So that's my story.
Thank you. We've reached 17:00. I don't know if there are burning questions or a burning comment, but I'm happy for us to close on that note.
So yeah, thank you again, Mati and Nabila, for presenting such an interesting and stimulating and one thought-provoking session. Nabila, just to give people a heads up for next week, about next week's session, what's
Public holiday, Yanis, we all going to be at home.
Oh yes, that is correct. I forgot about. I forgot that we have one. Okay, well, we'll see you at the session after that. Hope you all have a wonderful afternoon or evening.